My name is Mitch Linder. I'm here at the University of Rochester, though at home today. I just got home from work. And I'm a general gynecologist, so I see people for annual exams, through the age span of 14 through 99. And I also deliver babies, but I also specifically take care of patients who have vulvar, lower genital tract disorders and vulvar issues. Like lichen sclerosis and vulvar pain and things like that. And I see patients, we're in Rochester, New York. And if you know the anatomy of the Upper East area, right, I see people who come from Maine and Toronto and Cleveland and New Jersey, all to come up here because there's not a lot of people who do all the stuff that I do. I also am on the ASCCP practice committee. That's the committee that makes the guidelines for the National Pap smear guidelines. And so I work on that stuff. So I thought we could talk about that a little bit today. Um, yeah, that's what I've got. And so I want to encourage everyone's questions, but I know that sometimes people are shy. And so I put together a little bit of a presentation as kind of a choose your own adventure, so that we could pick a couple topics and then maybe that would generate some questions. And so if it's okay, I'm going to share my screen and I'm going to go through a little bit of stuff with you guys. So, okay, so we did our intros already. So I came up with a whole bunch of different topics that these are all reasonable things to talk about in the perimenopause or in menopause. And so I thought we could start by talking about a couple of these and then see where the questions kind of lead us for the rest of them, because I'm feeling that everybody's going to have questions about these are the major topics. So the first thing I wanted to start with is defining menopause, right? Because people ask all the time about menopause and am I there yet? And when's it going to happen? And so the average age of menopause is about 51.2 years, right? And there are some people, right, average. So there are some people who will go into menopause earlier or later. The key to know is it's a clinical diagnosis. It's a year without menses, right? And so if you are 52 and you have a period and then you go 8 or 9 months and then you have another period, you're not menopausal, right? Because it's a whole year. And so why do we care? Why does it matter? Mainly it's a marker, because once you hit menopause, right, your period stopped for a year. Any bleeding you have after that is a concern for abnormal cells or precancer or cancer. So if you stop having your periods at 54 and then at 59 you have a period, I'm worried. Same deal if you stop at 48 and then you have a period at 52, I'm worried. On the other hand, if you have a period every 6 months for a couple of years in this menopausal transition, in the perimenopausal area, I'm okay with that because that's usually physiologic and that your body's just kind of working its way through this. Now, some people ask, I don't have a uterus for some reason, right? Like I had a hysterectomy at some point, let's say. Is there a way I can do blood work to find out if I'm menopausal? And it turns out that the blood work that we do, the number one thing we check is a test called FSH. It's follicle stimulating hormone. It's something from the pituitary. And when I explain to people, I say, here's the deal. Basically, it's a hormone in your brain that yells down to your ovaries that says, have a period, have a period, have a period. And as long as you have a period, right, you have a cycle, it doesn't yell. It's okay. But like my kids, right, I got 4 kids running around here somewhere. When they don't do what you say, what do? You yell louder, right? And so if your FSH level is getting really high when we check on blood work, that's suggestive of you might be menopausal. The problem is, as you get into the perimenopausal, this transition that we're going to talk about in a sec, time period before menopause, your FSH could be high one day and 2 weeks later it could be back to normal range. And so therefore the blood testing tells a reflection of what today your body's doing, but not necessarily what your body's doing, over a time period. And so really it's a clinical diagnosis is the best way to define menopause. And then what if it happens too early? Really premature ovarian insufficiency. So having menopause kind of earlier than really you should is defined as below 40 years old. So Dr. Thornburg was talking about being perimenopausal. What does that mean? So perimenopause can occur up to about 8 years before hitting that clinically defined year without periods. And what happens? Some people can have some symptoms, which are all the symptoms we're going to talk about in a sec. Some people can have no symptoms, and other people have all of the symptoms. They have hot flashes and dryness and mood symptoms and weight changes. Um, and really, I wish that there was like a take this pill, it'll make you totally better. That's not the case. Really, all interventions should really be tailored to the individual patient and what symptoms they're having, whether and the severity and how they're impacting the patient. Okay. This is like fishing, right? Seeing if anybody makes me a question. If not, I keep going. Okay. So these are a bunch of different symptoms that I had that I thought we could talk about different things. Okay. So we'll go through those and see what we get. So one of the most common symptoms of either the menopausal transition or in menopause itself is vasomotor symptoms or hot flashes. So up to 80% of women experience some type of vasomotor symptoms during the transition and or after entering into menopause. Unfortunately, it's not like, oh, I'm menopausal, boom, they stop. Lots of people will have them after they actually have that clinically defined year without periods. Why does it happen? It's probably the body's reaction to having less hormones, right? Menopause isn't snap, no hormones. It's just a lower hormone level than enough to have a period, right? And the how quickly the hormones are decreasing, that's what triggers the hot flashes is the leading prevailing thought. And so therefore, some people will have hormone changes and have no hot flashes at all, and other people will have debilitating, can't talk through a whole sentence without having a hot flash. And so, I like to think of everything as least invasive to most invasive. And so least invasive is doing nothing, right? Because we don't have to do anything. Why should we be doing something? But for a lot of people, it's either impacting their quality of life or really disconcerting or just very bothersome. And so we talk about different things. And so the next least invasive thing other than doing nothing would be lifestyle changes. So we're talking about layering clothing, trying breathing techniques, doing meditation, and avoiding triggers, which can be alcohol or stress or spicy foods. And everyone's a little bit different. The next set of interventions would be things like different medications. And so there's hormone replacement therapy specifically, right? And so that's usually estrogen and a progesterone if you still have a uterus. If not, it's just estrogen. And that can come in the form of both oral or transdermal, so like a patch of estrogen. And then there's a low dose medicine called of a version of a medicine called Paxil, which is technically an antidepressant called Brisdel that's FDA approved for hot flashes. Effexor is another medicine that's technically an antidepressant but can be used for hot flashes. Gabapentin is a medicine that's used for nerve pain, but also works for hot flashes, especially night sweats, because it helps you both sleep through them and decrease the number that you get at night. And then last May, this new one called Veoza, which you may have seen on commercials, was approved. Because there's lots of commercials now. And it's a novel therapy in that it works in the brain to work on the temperature control sensor mechanism, basically. Um, and it works differently because it's not hormones and it's not an antidepressant, it's not a neuromodulator. Um, and so currently it's very expensive and it's hard to get approval from insurances, but there aren't a lot of contraindications. And so liver cirrhosis, kidney failure, and SSRI use are really the major contraindications to that medicine currently. Um, and we're going to talk about hormone replacement therapy in a couple different spots in a sec. Because it used to be that when we were talking about hormones, in the 90s, they thought, oh, everyone, we'll just give you hormone replacement therapy and it'll fix everyone's problems, right? If menopause is low hormones or no hormones, then giving you back hormones will fix the problem. And I remember there used to be a cover on Newsweek that had like hormone replacement therapy, the fountain of youth, and it was this big thing, right? And it turns out that for certain people, it's probably really helpful. And in certain situations, there's potential risks and harms. They did a big study in the 90s that was called the Women's Health Initiative, and they gave lots of people hormones. And then over time, they watched and saw what happened. And there were certain populations of patients that did really well with the hormones. It was very helpful. And there were certain ones who it was probably the the risks and the harms outweighed the benefits. And they looked at about 60 years old. It was about where the cutoff was of starting hormones. The best time to start hormone replacement therapy is right before, as you're entering that menopausal transition. And in general, the gestalt is lowest dose for the least amount of time, right? And so use it for enough time to get your body kind of through the transition, and then we see how it goes. But the patients who were started on hormones, like had never been on, had menopause, then were off hormones for a long time, and then were restarted on hormones at 60 or 65 or 70, those patients were more at risk for blood clots and strokes and things like that. And so it doesn't mean that you couldn't start on hormones later in life, but it's a big discussion about risks and benefits, because a lot of these things are quality of life things, which are very important. But there's risks to them too. And recently, it's a pendulum in medicine. It's always swinging one way or the other. And so in the 90s, they said, absolutely give everyone hormones. And then in the 2000s and early 2010s, they said, maybe we shouldn't. And now it's starting to the back to the fact that there probably are a lot of people who, doctors got scared off of giving hormone replacement therapy to, who could actually benefit from it for at least a while, right? It does have benefits to help bone health and heart health, colorectal cancer prevention, maybe dementia. And so therefore, it's probably not all bad. And it's probably a conversation that you should have with your healthcare provider, because there's probably no one size fits all answer to, who should be on hormones. Okay. If I skip around, I'm going to lose my thing. Let's do cervical cancer screening though. Okay. So cervical cancer screening. In general, the recommendation is to start doing cervical cancer screening at 21, and in the 21 to 30 range to do them every 3 years, assuming they're normal, and starting at 30 to do them every 5 years, and then continue every 5 years until about 65. Well, a lot of you probably remember when we used to do pap smears every year. Why the sudden shift? It's kind of shifted over time because we now know that HPV, human papillomavirus, causes like 99.999% of cervical cancers. And so if you don't have HPV when they do the test, which is a virus, the chance of you getting cervical cancer in the next couple of years is extremely low. And so most people now, when they get pap smears, they get what's called co-testing. They get a test for the cells, which is called cytology, and a test for HPV. If both of those are negative, then you get tested about every 5 years. Now, there's a chance that at 80 or 90, you could get cervical cancer. But really, if you look at the incidence of cervical cancer, usually it's young people, because the risks are multiple sexual partners, smoking, early onset sexual activity, and HPV. And it turns out that as time goes by, usually most of those get less frequent. And so the recommendations are to stop screening between around 65 years old if you've had 3 consecutive negative results, or 2 consecutive co-testing, which is abnormal cells and HPV, within the last 5 years. You also would stop if you had a hysterectomy at some point. If you had a hysterectomy and they removed your cervix, right? And so if you had a vaginal hysterectomy, or you had a laparoscopic or robotic or open hysterectomy, and they took your cervix, and you have no history of having really abnormal pap smears in the past, then you would stop, even if you were 42 years old. If you have abnormal cells in the past, though, you would keep going. And it's possible if you had an abnormal pap smear at 60, you would actually continue screening even past that 65, because we want to make sure that the abnormals aren't turning into normals. Now, an exception to this would be patients who had DS in utero exposure. Those patients were a very specific cohort of people from a certain amount of time where they got this medicine in pregnancy. The moms got this medicine in pregnancy to help prevent nausea and other things. And it turns out that the exposure when those patients were in the mother's womb caused changes to the baby's reproductive system. And so it made them a little bit higher risk for something called clear cell vaginal adenocarcinoma. And so currently the recommendation is to keep testing those patients even past 65, because there's a chance that as they get older, they'll have, because of this exposure, their results would be a little bit different. Now, caveats to this, right? This is cervical cancer screening. There's a difference between screening and diagnostic testing. If someone were to have bleeding, so someone came to see me at 85 years old and had that period. Remember I told you, like, they stopped having their periods at 50, they do well for years, and then all of a sudden I had a period. I had spotting when I wiped, I had a real period, I had blood through my clothes, whatever, at 80 years old. The recommendation would be to get an ultrasound to look at the uterus to make sure that there was no abnormal cells or anything going on in the uterus, but also do a pap smear, because what if they do have cervical cancer? And it would be different. Even if your pap smears had stopped at 65, you would do it because it's called diagnostic now. We're doing it to evaluate why and where the bleeding is coming from. We wouldn't keep doing screening because the average population doesn't need that. But in a specific sense for a particular patient, then we would do we would do a pap smear for that episode. We wouldn't restart doing pap smears annually or every couple of years, though, because you wouldn't go back into do screening again. There was a question about ovarian cancer screening. So unfortunately, there isn't very good testing for ovarian cancer, right? That's why, unfortunately, when people get diagnosed with ovarian cancer, it's often advanced in stage, because cervical cancer, some people will have, bleeding from. Uterine cancer, endometrial cancer, some people will have, oh, I got a period, after menopause. But ovarian cancer, the symptoms are often like bloating and fatigue and things that, if I have Chinese food, I get the next day. And so, given that, there's by the time someone has symptoms of ovarian cancer, usually it's advanced. And even patients who are breast and ovarian cancer gene positive, right? Those patients, when they're young, we recommend that they get ultrasounds every 6 months and blood testing every 6 months to check on their ovaries. Even those patients, when we're intensely monitoring them, usually we don't necessarily catch them early either, because an ultrasound is not a great screening test for ovarian cancer. And so it's not like, oh, I'm 50 or I'm 60 or I'm 70, and I go for a yearly ultrasound to look for ovarian cancer. If you had a cyst or something that, your doctor was following, yeah, we're doing it to make sure nothing's getting worse. But the average person, as opposed to going to get a mammogram or a colonoscopy, or a bone density scan or a pap smear just to see how things are going over time, ultrasounds usually are not used that way. Okay. Let's talk about muscle strength. So this is where we're going to talk about hormones also. So estrogen has been shown. I looked up studies for FSHD, right, specifically to try to answer your questions really well. Estrogen has been shown in some studies to be beneficial to myoblasts and muscles in FSHD patients, right? When they looked at these are all bench research. There haven't really been studies in patients themselves. It's mostly looking at actual muscle tissues, et cetera. And so when they did the study, the article hypothesizes that it turns out that males seem to be more affected, and there are a lot more female asymptomatic carriers of FSHD, and it's possible that it's the estrogen that is helping the muscle tissue, and so therefore that's why males are affected more, like have worse symptoms sometimes in this case. And they also talked about that they theorized that potential rapid loss of estrogen, right? So when you're going through the menopausal transition, could contribute to worsening clinical symptoms. Though the more studies I looked at, there was a 2018 study of 85 patients with FSHD who were female, and none of them showed a significant change in the disease progression with menarche, pregnancy, or menopause. And so those are all states where there's a hormone shift, either, right? So like pregnancy is a high hormone state, and then, when you're done being pregnant, you have a drop in hormones. So, patients sometimes lose their hair, for instance, for a while, right? Their hair falls out more fast in the postpartum state because of the hormone drop. But none of those patients seem to show to have significant progression of their FSHD symptoms within that hormone dropping period. I also found that there's this starfish trial that's ongoing at the University of Rochester, actually, that's looking at growth hormone and testosterone in men to see if those are things that would help prevent muscle loss and muscle degradation. They recruited like 60 patients, and they just finished And so they're working on like kind of getting the results out. But some of it's still ongoing as some of that research. The 85 patient study was an observational study, yeah, because they didn't watch the patients the entire time for menarche, pregnancy, and menopause. Yes. Um, okay. I'm looking through all the questions too. Okay. Um, okay, let's talk about vaginal dryness. So vaginal dryness is another super common complaint, and sometimes that's actually the first complaint that people come in the perimenopausal period. So you're 48 years old and you say, I really have more vaginal dryness. Either, I notice it exercising or walking around or with discomfort with intercourse. Um, and it impacts, it's a very large range because as Dr. Thornburg pointed out, it turns out that because there's nobody talks about this, right? And so people don't usually talk about it in their families. Like, people, when I ask people, like, even when did your mom have menopause? Because sometimes it turns out that it's hereditary. If your family members have later menopause, then you might have later menopause. Most people don't know. And so studying these numbers is really hard. So it says it impacts 27 to 84% of postmenopausal women. That's according to the North American Menopause Society, right? And that's like the preeminent menopause literature place, and they have a very wide range because it's probably underreported. It's probably much higher than the actual number of what it is. Um, as estrogen drops, there's a thinning of the vaginal tissues related to that decreased estrogen. It has other names too. So there's one that's called atrophic vaginitis or vaginal atrophy, or more recently, there's this combination of symptoms that's been titled genitourinary symptom of menopause, GUSM. Um, if it's a dryness issue, sometimes those symptoms can be exacerbated by pad use. So if you have leaking of urine and you're wearing a pad and you're doing a lot of rubbing because the skin is dry, that'll make your symptoms worse. It may contribute to increased urinary frequency symptoms and recurrent UTIs if you're having this dryness because of change in the vaginal environment. Um, and so, you know, like I said before, I tend to look at things as least invasive to most invasive. And so the least invasive thing to do is to use over-the-counter things. So depending on where you are, Refresh and Reflens are two brand name products that live in the same aisle as like condoms and vaginal moisturizers. They're about vaginal moisturizer specifically that you would put in the vagina a couple times a week to help keep things more moist, the same way that you might put something on your elbow if you have dry skin. Coconut oil works really well too, right? I tell people all the time that it's probably cheaper than most of the other products, and as long as you're not allergic to coconuts, it's absolutely fine to use. And there's other over-the-counter moisturizer products as well. If you're having problems with external symptoms like from you rubbing on pads, then you can use barrier creams for protection against chafing. Um, those things I tell people you would find them kind of in like the baby aisle, so it's like Desitin or A&D ointment. There's one called butt paste or CeraVe or Aquaphor. Any of those would be fine because they keep, it's a barrier, so it keeps the good moisture in, and then it helps prevent the rubbing also. Um, Going into the prescription type things, there's vaginal estrogen products that can be used. So the nice part about vaginal estrogen is it's not systemic. So when you take a pill, it goes through your liver, and there's all these risks of blood clots and strokes and high blood pressure and things like that. But vaginal estrogen works locally, so it just works in the vagina. And so I tell people to think of it the way steroids are too. If you take oral steroids, and you go to a desert island, you're probably going to gain some weight. You're going to have trouble sleeping. You might get a little roid rage. You might get some acne, right? But if you use steroids from a local pharmacy on your arm for a rash, you usually don't get any of those symptoms because the skin use of steroids doesn't go anywhere except for where you put it. And so vaginal estrogen products are a little bit uh, tamer than using oral estrogen products. And so vaginal estrogen products would be there's a cream version you can do it. There's a tablet version you could use, and there's a ring version that's like you leave it in for a couple months and it works to slowly give up estrogen. There's also a vaginal DHEA product, which is It's a precursor to testosterone. And then there's a vaginal testosterone that you can get made to use in the vagina, which is a precursor to estrogen, depending on how it gets metabolized. There's also systemic estrogen products, so like we talked about, oral and transdermal. And then there's a separate medicine that's called osphena, which can be helpful for bone health and as well as for pain with intercourse and vaginal dryness. Um, it's it's a special medicine called a selective estrogen reuptake modulator. It's similar to a medicine they use to help prevent breast cancer. Speaking of pain with intercourse. So the first thing to know is sex should never be painful. So I see patients all the time who come in for their annuals or for other problems, and they're not having sex. And usually, I ask them always, like, why, right? And there's a couple different answers, right? Sometimes it hurts and I'm having trouble or dryness, etc. Right? Some is he can't get it up. He has prostate stuff, he's on medicine, he whatever. Some of it is we're just friends. I'm okay with the second two. But if sex is painful, we should work on it, right? It's not always going to be the same as when you were 20, but sex shouldn't be painful. And usually there's interventions that can help or really improve things. And so potential interventions include things like lubrication, right? And so, you can use things like Astrolite or KY, but that coconut oil we talked about for vaginitis works awesome as long as no one's allergic to coconuts. I tell people all the time, it's used for dry skin, so people use it on their scalp and on their elbows and things like that. It's inconspicuous by the bedside. It's cheaper than Astrolite and KY. It coats pans well, right? Like, so it lasts long. It starts as a solid and turns into a liquid, so it's a little bit easier because it's not as messy. And it's edible, right? And so therefore, coconut oil is great, and we recommend it all the time. People do great with it. There's those vaginal estrogen products. Those work by thickening that, trying to reverse that thinning of the vagina related to the natural drop in estrogen. Same with the DHA and testosterone. Same with the oral estrogen products, and same with osphena. Let's do itching conditions. Okay, so vulvovaginal itching conditions. So there are a lot of conditions, right? When people are like, I'm having itching, the first question I ask is where, right? Is it in the hair area? Is it in the vulva area, which are the folds? Or is it in the vagina itself? Because it turns out that although it's like, I'm just itchy down there, there's a lot of different reasons that people get itching. And if you just keep getting treated for a yeast infection and it's not getting better, it's probably not yeast, right? And so one condition that is common to get postmenopausally is called lichen sclerosis. It's probably an autoimmune condition. We don't exactly know why people get it. It seems to affect premenarchal little girls, so like 7-year-olds and postmenopausal women. Something to do with having estrogen is usually protective. And it usually causes vulvar skin thinning, as well as tearing and intense itching. And so some people will have it and it will be asymptomatic, other than, it looks different. Other people are like, I am itchy all the time and it's absolutely terrible. And what can I do for this? My doctor just says, oh, this is normal aging, but it's terrible. And it turns out there's lots of interventions we can do. Usually you start with topical steroids. It's also a condition that, because it's a skin condition, there's a chance that it could turn into precancerous or cancerous lesions of the skin. And so therefore it's important to, even if you have well-controlled lichen sclerosis, I tell people it's important for someone to look down there about every 6 months, just to make sure nothing's changing or doing differently. So the second condition is this one, it has the same start. So it's also called lichen, because lichen has to do with skin change. Simplex chronicus. It's different in that usually it doesn't have physical findings you can see. It's mostly like a neurologic condition. And so things actually look normal, and with quotes there. But but you get intense itching without significant skin cleansing. And sometimes it's precipitated by an event. I went in a hot tub, or I had I had a pneumonia. I took a lot of antibiotics, or I was in the hospital for a while. Um, and then people went with this really intense itching, and it really doesn't get better until it's treated. And because it's a diagnosis of exclusion, it sometimes takes a while to get thought of as a choice for this is what's going on to me. And then the treatment is usually multifactorial to give a lot of different things to kind of calm down the skin. You can also get skin yeast infections. So when people think of yeast infections, they think of thick white discharge. The problem is you can also get yeast infections underneath a breast or in a fold of your belly, right? You can get them behind your knee, or you can get them between your toes. And so not all yeast infections are thick white discharge. And so if you have it on the vulva folds, and people look in the vagina and say, well, I don't see any yeast in there, it doesn't mean you don't have a yeast infection. It just means they looked in the wrong spot. And so sometimes, when I see patients who have chronic itching, I always do a yeast culture off the skin, where I swab the vulva and I send it off, because most skin yeast infections are Candida yeast and albicans, which is a type of yeast. But there are some that are more resistant types of yeast, and therefore they need more stronger medicines or longer courses of medicine. I'm just reading more questions. Okay. There's a question about home compounding of estrogen creams. Um, like taking some of those vaginal tablets, let's say, or I guess maybe oral tablets, and mortar and pestiling them into um with other things, like putting in a moisturizer or an aquifer or something like that. Um, and whether that's allowed. Um, Personally, right? I don't know anything that would make that illegal, right? You can use things however you want. I use a medicine. I prescribe people a medicine that's usually used for hemorrhoids, which is a rectal steroid, to put in their vaginas to help with certain conditions, right? It's, the equivalent of off-label use. So I don't think it's not allowed. I think that getting the prescription, you could tell the prescribing provider that that's okay, and that, like, this is what I intend to do with it. Or you could just say, sure, I'm going to take the tablets and do what I'm supposed to do with it, and then do whatever you want with it. I don't think it's dangerous as long as it's working. Sometimes if the compounding, I actually send lots of prescriptions to a compounding pharmacy to make vaginal estrogen compounded, because it turns out that a lot of insurances don't cover the two brands of called estrase and Premarin, and so we do compounding all the time. But so home compounding is probably fine. The risk is like uh, sterility and cleanliness is probably the biggest risk. Make sure you're not contaminating something where you're going to put on your body or in your vagina. Um, I had, I had another question about um, screening for vulvar cancer. Some of that goes with that screening for lichen sclerosis. When I do annual exams, and you're not needing a pap smear, for instance, I don't always do a speculum exam, right? Because it turns out that just because I can do stuff, I shouldn't necessarily do stuff. And you're 85 years old and you come to me for an annual. What? I don't have to look in the vagina if you don't have any problems, right? But I do look at everyone's vulva, right? The chance of vulvar cancer is actually really rare, right? The risk of getting breast cancer, even with no family history, is about 1 in 8 or 1 in 9. For comparison, the risk of um, ovarian cancer is like 1 in 60. Vulvar cancer is actually 1 in a couple hundred, right? It's actually pretty rare. It's not like, definitely people get it, but it's not as common as breast cancer or some of the other cancers. Um, and so usually, your doctor should take a look just to make sure that everything's doing okay. And then if you have anything that you're concerned about, to take a look also. Um, there are certain conditions that you might want to look more often. So like in sclerosis, I tell patients we look every 6 months just to make sure nothing's changing. But if you have a history of certain cancers, so uterine cancer or ovarian cancer, usually they're separate organs that just happen to be near each other. So, for instance, if you have a hysterectomy for uterine cancer, you don't need pap smears anymore, right? Because they'll take out your uterus and your cervix. But as long as you haven't had a history of abnormal pap smears, just because you had uterus cancer doesn't mean you need pap smears in the vagina. Usually that's discontinued. That's the recommendation. So in the same way, for vulvar screening, you wouldn't need extra screening if you had uterine cancer or if you had ovarian cancer, because they just happen to be close to each other, but they're all separate organs, kind of. Okay. Let's do bone density and bone health. So when you hit that menopause, like the official clinical menopause in that area, there's about a 10% loss of bone mass in the first 5 years of real menopause. Some studies have shown that about a third of FSHD patients are deficient in vitamin D3, and they have a higher incidence of fracture than the general population. And I presume it's not just because of the loss of bone mass, but it's probably because of a multitude of things that have happened, throughout their lives, right? Your guys' lives, right? That makes you a little bit higher risk between balance and things like that.
Hey, Mitch,
Yeah.
um, I love you, but there's a comment if you could just slow down just a skosh.
Yeah, I talk really
I know
fast.
you've definitely heard that before in your life, right?
Yeah, I talk really
Yeah.
fast.
Can you talk a little bit about pharmacy over-the-counter hormones like
Yeah.
estrogen, DHEA, using some of those?
Yeah. Yeah. So there's a lot of products that exist both on the internet and over the counter. Um, Whether it's alternative therapies like St. John's wort and black cohosh and things like that versus over-the-counter products. Most over-the-counter products don't have a lot of estrogen or testosterone because those tend to be a little bit more regulated. Most of them are probably safe. The problem with things that are not prescriptions is that, if they're working for you, that's wonderful. But if they're not regulated through the FDA, right? So like even vitamins, technically, there's a chance that it doesn't have what's advertised, or not every pill is the same, right? So if you get a bottle this time and a bottle next time, you might not have the same amount of stuff in them. And so it's not that you can't use any of those things or they're not necessarily safe and you're going to overdose on hormones. But the idea is really we should aim to use things that are kind of more regulated just to make sure that it's safe for your body. Um, Someone asked about when should you stop going for a yearly visit with a gynecologist. So interestingly, I get asked this question like 2 or 3 times a day. And I always have the same answer. It's a little bit of patient comfort level, right? And it's a little bit of history and a little bit of the relationship with the provider. So I have patients I see every year, right? And I've seen every year for 15 years. I have other people I see every couple of years. Medicare, as an insurance, will cover an annual well woman check every 2 years. It's absolutely unfair that a male patient can go every year to their doctor and a female can't go every year to their female specialist doctor for free. But that currently is what's going on. And so it's the same answer that I give people when they ask about when should I stop getting a mammogram, right? So it turns out that if you wouldn't want the intervention, you probably don't need to go for the test. So, if you go for a mammogram today and you're 85 years old and it says you have a small 3 millimeter calcification that's concerning for breast cancer, and you would say, I don't want a biopsy, or, you have the biopsy, but I don't want the surgery, or I wouldn't want the chemotherapy or the radiation, then you probably don't need to go for the mammogram. right? And so I've had 65 or 70-year-olds who don't go for mammograms. On the other hand, I had a 90-year-old a couple of years ago who went and got a mammogram and it said breast cancer, and said, she told me my great granddaughter something is in about 6 months and I really want to go. And so she went through the treatments and did great. And then she went to the great great granddaughter's performance. Um, Same deal for bone density scans, which we're going to talk about through this. If you would say, I would never want to go on one of those bisphosphonates, which is a medicine to help with bone health, you can go get the bone density test, but the intervention is either, you're good or I don't want the intervention. And so some people go for the bone density tests and you do them every 2 years. And other people choose not to do them, and that's okay too. I'm a big proponent of, shared decision making, which means talk to your provider, come up with a plan that you're both comfortable with, and you kind of go from there. And I tell the patients, if I'm not going to see you next year, that's okay. I'm always here if you need me. And some patients it's I'll see you when I see you, and other people are okay, I'll see you in 2 years, and other people, no matter what I say, they're going to come back next year and talk to me, and that's absolutely fine too. Um, so we were talking about bone density and bone health. Um, Interventions would be things like weight-bearing exercise to help kind of retain muscle mass, because muscle mass goes down when you hit less estrogen states, and really to do fall prevention things. So yoga and balance related activities, even aqua aerobics helps. Um, Doing things like gripper socks so that you don't slip on any hardwood floors. Wearing glasses on chains so that if you get up at night and you can't see, you put your glasses on and you can find them. Um, Improving lighting at night. So if you have to go to the bathroom and down a hallway, you're not going to trip on something. They actually have even fun lights. I have a bunch of little kids, and so I have a light that's right by the toilet that when someone goes nearby, it automatically turns on so they can find the toilet, because I had people who were missing the toilet sitting onto the floor. Um, that's a lot. It was like $10 on Amazon. It was great. I got a whole set of them. And to remove slippery rugs and things, right? Because if you slip on your rugs, then that's a problem. And really, we don't want people to fall and break their hip or break their shoulder or something like that. There's also medication. So I talked about like bisphosphonates or even systemic estrogen. So oral estrogen can sometimes help with bone health. And that's where we talk about, the risks and benefits of the treatment. And then when to get a DEXA, which is a bone density scan to see how your bones are doing. The average human recommendation is for starting at 65 years old, but anyone with risk factors would be earlier, which often includes a baseline scan about the time when you become menopausal. And then based on that first scan would depend on how often you do it. So people with chronic steroids, people who are more sedentary, people who there's this are on thyroid medicines. There's a bunch of conditions that would cause you to trigger you to go for a bone density scan earlier than the normal 65. Um, Body remodeling. So people ask all the time about, weight gain during the menopausal transition or during menopause itself. And it often starts in perimenopausal time. And it's probably due to changes in metabolism, right? And it's probably related to decreased muscle mass and less activity, right? The average weight change during menopause, like in the first couple of years, is about a pound and a half gain. Um, and muscles burn energy a lot. Well, if you have less muscle mass, then you're not going to burn in many calories, right? And so that's where exercise is important. Um, Not only that, the location of fat stores changes too, right? So when you have more estrogen, your fat stores tend to be in your hips and your thighs and the back of your arms and your breasts. But as you transition into menopause, more of it tends to transition to being in your midsection of your abdomen. And so a lot that's, disconcerting for a lot of patients. Their clothes don't fit the same. And no matter, I see patients all the time that say, no matter what I'm doing, I'm having trouble losing the weight. I eat well, or I don't eat much to begin with. I exercise, I've been walking, and I'm still not getting the weight off. And it turns out there isn't a quick fix, unfortunately, because it has to do with kind of an overall picture of what's going on. The hope would be that your body will kind of steady out and your new metabolism will kind of take over, and then we could work to adjust things after that. Okay, so pelvic relaxation. So another thing that's very common in the perimenopausal transition or menopause is to have issues with pelvic relaxation. There's kind of two topics that fall into that compartment: urinary leakage and pelvic organ prolapse. Urinary leakage can be as little as a couple of drips to absolute complete incontinence. Some people have stress incontinence, so cough, laugh, jump, and they leak. Other people have urge incontinence where they, by the time they feel they have to go to the bathroom to urinate, they can't make it to the bathroom and they leak. Some people have involuntary leakage urine and they don't even feel it and then they just leak. And depending on what the cause is, there's different interventions. So like pelvic floor exercises to strengthen the muscles around, holding it, versus oral medications to calm down if it's because of bladder spasms, versus Botox to strengthen the muscles, to freeze them up, versus surgery to kind of lift the bladder up. And usually, urologists do this, some gynecologists do this, and there's also often specialists called urogynecologists who are kind of a mixture between urologists and gynecologists who specifically work on this kind of stuff. And then pelvic organ prolapse is kind of when different organs are kind of falling down a little bit. And so if you think of a hernia, it's a weakness in your abdomen where something kind of pops out, right? This is the same idea. The vagina is kind of a potential space. It's kind of like a sock, right? Most of the time it's closed, but you can put things in there. In the same way, your bladder sits on top of your vagina and your rectum below it and your uterus at the top. And if there's weakening of the structures, then things can start to fall into the vagina or prolapse all the way out. And so depending on what's going on, some people are symptomatic and some people are asymptomatic when they have these things. And so there's pelvic floor exercises to try. Sometimes people can use a pessary, which is a space-filling lesion, and sometimes people have surgery for these things. The last one I've got is mood stuff. So lots of people have mood changes in this, either the perimenopausal transition or postmenopausally. Again, this is probably an underestimation that, it's 4 in 10 women who have issues. Depression is a common component, but it's increased, right? Why this happens could be hormonal, but it could be many other things, right? It could be related to stress. It could be related to body changes, so people are sad about that. It could be related to hot flashes and not sleeping well, right? There's all these different components. It could be relationship issues to having dryness or pain with intercourse. And it could just be related to people in their 40s and 50s are sometimes often at the peak of their career. And so this is the most busy time of their whole life. And so potential interventions could be improving sleep. It could be improving exercise to get those endorphins going. It could be cessation of smoking. It could be going for counseling to work on, why are you having the moods symptoms, or oral medications. That's the end of the topics that I have. I think
we have 3 minutes left.
Yeah, well, I was trying to be good.
You did an excellent job. I'm just wondering if we have any extra questions out there that anyone would like to put in the chat so that Dr. Linder can answer. We really appreciate both of you sharing your expertise and your time with us this evening.
Somebody asked me about Kegels for pelvic floor. I just wanted to point out that pelvic floor physical therapy is a whole discipline in and of itself, and referral to a pelvic floor therapist can be really helpful, not only for incontinence or pelvic floor, spasm, but can also be really helpful for painful sex or a variety of pelvic floor issues. And so if there's, do not be hesitant to ask your doctor for a referral to a pelvic floor therapist. They really are impressive in their help. I'm also going to put a link in the chat for a video of how to actually do just some basic pelvic floor exercises for hypotonia. It's more than just Kegels, like we think of, like you just like try to stop peeing, but marches and heel slides are part of it too, and diaphragmatic breathing. So I'm just going to put a YouTube link in there because I think it's just nice to see a pelvic floor therapist take you through some a basic video of how to do some of them. And my rule is that if I'm ever at a traffic light or have to watch a commercial on YouTube or on network television, and I almost never have to watch commercials anymore, which is nice, but I will do pelvic floor therapy during any commercials or red lights, because that's something I can do while I'm sitting there. And so
Well, and
it's a nice thing
I
to
tell
do.
people all the time that uh, Prozac should probably be in the water too. Everyone would just be happier. But pelvic floor physical therapy is the same deal. Everyone could probably benefit from pelvic floor physical therapy.
I also
Even if you
helped
don't
with
think that
the
you need it.
yes, I helped with the international guideline for FSHD after pregnancy care, and one of our recommendations was universal pelvic floor PT after delivery. Given, I think everybody should go to pelvic floor PT after delivery, but especially people who have a neuromuscular challenge, because I think it's an important area that gets neglected. And I don't know any woman who's delivered vaginally or by C-section who doesn't have a little pelvic floor dysfunction, regardless of whether they have any underlying muscle issues. One point I wanted to make is estradiol. Getting scripts is really difficult. You can get over-the-counter estrogen. It is available from Amazon. You can get it as a topical through your skin absorption. There's a lot of different brands. Be really careful. Some of them are, differently regulated. It's really hard to know what you're getting, but it is possible to get topical estrogen creams.
The other thing is, if you're having a problem finding someone who takes care of patients in menopause, the North American Menopause Society has a whole website that has a provider list that if you look on that site, you can find someone, I presume, in your area who does. There are also places that now do televideo, like telemedicine, just for hormones, like for discussing hormones and menopausal things. So even if you don't have someone in your town or your area, there are lots of ways to access this care.
Another
It doesn't
great
have
way
to
to get it. Remembering though,
So-
if you take an estrogen, if you have a uterus, you need a progestin as well. You can't take unopposed estrogens, or you will increase your risk of uterine cancers. And then a couple people asked about the new weight loss drugs with menopause and weight gain. And I think this is a really interesting area, and one that me and all of my perimenopausal friends have been talking about a lot, my doctor friends. And one of the things I think that's really concerning about these new injectable weight loss drugs is there is data that there's a lot of muscle loss with the new injectable, like the Wegovy's and the Mitch, give me a name. Ozempic and those kind of.
The way they work is they kind of block your hunger, or your ghrelin, which is your hunger stimulation.
Yes, they block your hunger.
It's effectively starving you a little bit on purpose. And so if you need protein to help your muscles stay up.
So if you're going to do one of those, you really need to focus on intake of lean protein and making sure that your protein intake is appropriate, because we know that one of the challenges with FSHD is muscle loss. And so we need to be really careful that that's not one of the things that's going to happen to you in later life, because we know that that is one of the risk factors for death in your 80s and 90s is muscle mass loss. So weight bearing as we age is also a key to bone health and to muscle mass maintenance. So if you're using one of these for weight loss, even small amounts of, I know that exercise is difficult, but it doesn't have to be, clean and jerk 500 pounds. You can be lifting soup cans from your chair, and it can be very light weights, but keeping up with muscle tone is going to be critical if you're using one of these. There's also some of the other appetite suppressants that are not as muscle wasting, things like Qsymia, which is another appetite suppressant that is not as much muscle loss. So, you know, another choice. There is no magic bullet, unfortunately, but the high protein, lower carb, and using these as a tool in your toolkit, not as a cure-all, is really seems to be the people who have the most success. So I would also put in a plug for anybody who has limited mobility. If you have the option to add exercise programs that utilize zero gravity, like water therapies or water aerobics as part of your therapies, those can be really great ways to add exercise without adding joint or physical stress. And again, are also really nice for people who struggle with pelvic floor issues or leaking or things like that. I know that's an issue for many women when they go to do land-based activities, but is much less intimidating in the water. So something also to consider. So
I got a question about how Botox for urgent continence works. Botox works by strengthening the urethral sphincter to help keep continence. So it bulks it up for a while to help prevent leaking.
Mitch, you broke up a little bit. I'm not sure what you said.
Oh, it's fun. I didn't sound like I broke up. Botox for your urgent continence, it works by making the muscle tighter. That's why I was doing this. Right? It paralyzes the urethral sphincter muscle. That was one of the questions.
Okay. The other plug I'm going to put in for vulvar health in the perimenopausal time or menopausal time, and especially for people with limited mobility and for pregnant people, which I realize is, you know, less of the people in this group, is I'm going to put in a plug for the bidet. And trust me when I say that it is a life-changing thing for women over 40, because I do think that making sure that you're fecally clean and urinarily clean also helps with itch and irritation. And we know that you know, barrier creams can be helpful as well, but there is a lot of good data that is another way to help with irritation and itch. So they're very easy to install. They're cheap now relative to what they used to be, and they can be put onto a regular toilet, and something to consider if that's an option for you. So I made my husband install one in every toilet in our house, and he'll never go back. He told me that he finally agreed that I was right. So just saying.
That's a good plug. That's a very good plug, because we do discuss that quite frequently, that the
So,
benefits
you know,
of the day.
Mitch and I, you can't make us embarrassed. You know, we're gynecologists. Like, there's nothing we haven't heard, which is why I'm saying these parts out loud, because I know that sometimes it can be hard to be the person who's like, you know, the thing when your undercarriage does the thing. So I'm just going to tell you that, you know, at my house, these are conversations that I have with my own children, with my own friends, and we do talk about these things on our own walks.
We moved into our house maybe 10 years ago, and I went into the bathroom, the master bathroom, and I closed the door, and it turns out that they already had a built-in bidet, like a real one, not like a top.
Oh, you had like
in
a
our
real
house.
bidet, like a
We
European.
have a real porcelain toilet and a real porcelain bidet, and yes, it is functional.
So can I ask just one more question that came to me? It's about progesterone and estrogen, and the need to do both of them if you still have a uterus. Can you explain that just a little bit further, please?
Yeah, so estrogen and progesterone do different things, right? So estrogen is stimulating to the uterine lining, so it makes the lining build up. And so it's a growth though, right? And so the longer it stays there, the higher chance that it's going to turn to abnormal cells or precancer or cancer. What progesterone does is it helps either turn over the lining, so it causes you to have a little bit of bleeding to shed the lining, or to keep the lining thinner so it doesn't sit there as a growth. And so if you have a uterus and you're taking estrogen, you really should, but you really have to take progesterone as well. If you don't have a uterus though, then you could just take estrogen because you don't need to protect your uterine lining.
Excellent. Thank you very much. Now, we're over time and we want to be respectful of your time because I know it's the dinner hour at your house and you have 4 kids and they're probably pretty hungry. And I know Dr. Thornburg has some little ones too.
Well, mine are big. I'm about to have an 18-year-old on Saturday.
Oh,
So
goodness.
if you want to vote in the chat, my house is voting on whether they're coming home with a tattoo or a nose ring on Saturday. So, but the money's on nose ring right now, but.
Bless you. Bless you. I have a 40-year-old and a 37-year-old. So been there, done that. But
Yeah.
yes, yes, yes. Thank you, both of you. Do we have any last questions, quick questions? I don't see any. Do you guys see any in your queues?
No, I don't have anything left in my queue.
And I think I answered them, but if I missed something, I'm sorry.
So is it possible that I could receive your slides? I promise I will not. I'll
Yeah.
PDF them. So
Mitch, we had a question about osphenia. I missed that.
Aspina?
Yeah,
Yeah.
osphenia. Did you
Yeah.
answer that one?
That didn't come to me. Aspina is a medicine. It's FDA approved for dryness and pain with intercourse. It works well, but it's an oral medicine they have taken. It's only been approved for so long. So therefore, like, it's not used as much as some of the other things like vaginal estrogen because that other one's systemic. But it works. And yeah, I'll send my slides, absolutely.
okay. Thank you both
All right,
very,
thank
very
you.
much. We really appreciate it. Have a lovely evening. I hope it's not snowing at your house.
No, it's lovely here.
No,
So.
we're doing okay.
All right. See you guys soon.
All right. Thank you so
Thank you.
much.
All right. Bye-bye.
Good night, everyone.